Welcome to Rounds. Dr. Verbora completed his medical degree at the University of Western Ontario and then went on to complete his family medicine residency at Toronto Western Hospital. Prior to his medical studies, he completed his MBA from the Odette School of Business, and his clinical interests are in cannabinoid medicine with a special focus practice designation in pain medicine. He has completed over 2,000 initial consultations for cannabinoid therapy and is also presenter for the Ontario College of Family Physicians annual Windsor Pain Conference on cannabinoid therapy. He is a member of the Canadian Consortium for the Investigation of Cannabinoids, Doctors for Responsible Access, and the Canadian Pain Society.
Okay. Good morning. Sorry for being late today. Thank you for having me, and I'm happy to be here to provide a little bit of information regarding medical cannabis. Just for disclosure, I do have a minority stakeholder share and I help operate, and I have received honorariums in the past for the presentation. I do not receive anything for today's presentation. I'd like to talk about a couple of different things today. One is the endocannabinoid system. Two is some indications and evidence for cannabinoids, specifically for some areas or symptoms that you may see. Address some of the risks and harms of medical marijuana, methods of consumption, go through prescriptive dosing as well as documentation that physicians should prescribe down the road. Before I get started, I want to talk about a little bit of confirmation bias. There's still a lot of issues that really prevent us from getting the right data regarding cannabinoids. When you label cannabis as a Schedule I drug in the United States, you really are limited to access in terms of studying this. And then only the DEA or other organizations provide you with specific types of cannabis. And then the type of cannabis they provide you with is generally low potency cannabis. So that was a big problem. In addition to that, if you scan the literature and look at the studies that have been funded for the longest time, you see that the majority of them are really looking at primary outcomes to prove something negative rather than positive. And today we don't really have a lot of studies with one of the other ingredients in cannabis plant, the non-psychoactive ingredient CBD. You know that is a quite medicinal ingredient. And a lot of studies that show negative outcomes tend to be in recreational users, and I think that's a different population than the medicinal users. So that's all the information you have to take into consideration when looking at the literature. So on one hand, the DEA says that cannabis is a Schedule I drug, which means it has zero medicinal benefit. And then on the other hand, the United States of America, as represented by the Department of Health and Human Services, owns a patent on cannabinoids, antioxidants, and neuroprotectants for the brain. So I'll just leave it at that. Let's get into the endocannabinoid system. So you can just think about the answer yourself. Is the endocannabinoid system A, found in virtually every organ in the body, B, limited to our central peripheral nervous system, C, well represented in the brainstem, D, responsible for a flight or fight response, or E, clearly defined in its function? So the answer is A, is found in virtually every organ in the body. We'll give some definitions. Cannabinoids are the compounds that act on our cannabinoid receptors in the human body. Endocannabinoids are the endogenous cannabinoids that we produce. Phytocannabinoids are the ones that we find in the plant. And then, of course, synthetic cannabinoids are the ones we see, usually pharmaceuticals such as now. There are street drugs that are also synthetic cannabinoids, known as spice and K2. They're actually quite wonderful, but they're not medicinal at all. There's two main types of receptors in the endocannabinoid system, CB1 and CB2 receptors. CB1 receptors are normally found in the brain. The majority of the entire brain does have receptors, except one very important part. And that is the brainstem. So unlike other drugs such as opioids and benzodiazepines that have that take action on the brainstem, cannabinoids do not interact on the brainstem because there's no receptors there. And I think that's an important distinction when you're looking at suppressing respiratory drive. On the other hand, CB2 receptors are found throughout our immune system. And so there's a high density of these receptors throughout the immune system. But I can't say that we fully understand exactly what's going on in the immune system with cannabinoids. The endocannabinoid system is a lipid signaling system, and if you look at the basic science research, we do know that it's quite important, and it's involved in numerous different cellular processes, from immune function to inflammation, to metabolism, energy, bone development, memory regulation, stress and emotional states. It's quite an important system. It is believed to be necessary for biological life. Even in organisms such as nematodes have endocannabinoid systems. To date, we believe we have discovered about 10 endogenous cannabinoids. The two most popular are anandamide and 2-AG. And the phytocannabinoids in the plant, there's about 70 different cannabinoids, but we do believe two of them to be the most medicinal, and they're the highest concentrations in various strains. That's THC and CBD. THC and CBD, again, are the most medicinal ingredients in the plant. THC is a partial agonist to the CB1 and CB2 receptors found in the brain immune system. It is, however, responsible for some of the psychoactive effects that patients experience when using it. It is known to be effective for acute pain, muscle spasms, and perhaps helping nausea and stimulating appetite. CBD, on the other hand, is quite interesting. It is a partial antagonist of THC. So it almost can block a little bit of THC. It also works by blocking enzymatic breakdown of our endogenous cannabinoids. So it can boost the levels of 2-AG or anandamide in our body. It has been shown to activate other pathways such as adenosine and serotonin pathways. It is not psychoactive, and it has a role in terms of anti-inflammatory, analgesic, antiemetic, maybe antipsychotic, antihistaminic, anxiolytic, and anti-epileptic effects. And a lot of these are really just doing study now. So it's quite interesting when you look at THC and CBD. It's a little bit, to use some Eastern medicine terminology, a little bit yin and yang. Synthetic cannabinoids, there's a picture there of abalone. This is the only synthetic that we can prescribe here in Canada, and it is a THC analog. So it's going to bind to CB1, CB2 receptors, and binds slightly stronger than THC. But it doesn't have all these other ingredients that I'm going to get to. Sativex is a whole plant extract. It's a clever company, I must say. They've been able to get a drug identification number for a plant product, which not do for cannabis. This allows it to potentially have coverage and allow it to travel over borders, unlike plant cannabis. This is a one-to-one mix of THC and CBD, but it also has other ingredients in the cannabis plant. And they have some type of proprietary spray technology, but it comes at a premium cost. When you compare synthetic versus natural, now is a single molecule, it's a standardized dose, has no longer onset of action, no longer duration typically. When you compare that to herbal cannabis, if you're inhaling, which will have a shorter onset of action, shorter duration. But the herbal cannabis has 80 cannabinoids. That's what makes it so different compared to a synthetic. And it has these other ingredients called terpenes and flavonoids. And there's over 350. So in any single strain of cannabis, you're looking at about 400 to 500 different ingredients. And what we believe is there's something known as the entourage effect. And that is that all the various compounds in the plant work in a manner together, perhaps cooperatively, to achieve best results. Or perhaps different strains with different profiles of terpenes and flavonoids will produce different effects on the CB1 or CB2 receptor. We just don't fully understand exactly how that's working. But that would explain why some strains give you energy and some strains give you sedated. If you look at what goes on in the synaptic terminal with regards to signaling, essentially what's happening is at the postsynaptic cell, at the bottom of the diagram, there's usually a stimulus which causes production of an endogenous cannabinoid. And then that migrates across to the presynaptic cell, which would then bind to, for example, the CB1 receptor. And essentially what happens is a retrograde transmission, and it's a suppression of neurotransmitter release. And the way that I communicate this to patients is essentially there's a relaxation of the nervous system. The entire nervous system can calm down and be quiet when you use cannabinoids. In immune cells, we do know that CB2 receptors affect the release of cytokines, chemokines, neutrophils, macrophage migration and change, and it does somehow affect our immune system function. And then the other pathways that are affected are glutamate, GABA, and dopamine as well. So to summarize a little bit about the cannabinoids, it's the high density receptors in our immune system in the brain. There are no receptors in the breathing centers of the brain, particularly the brain stem. It is a lipid signaling system. THC and CBD are the most therapeutic phytocannabinoids, and there is something known as the entourage effect, we believe, that enhances perhaps the effects of different cannabinoids. There are two synthetics available. Mind you, Sativex is not really a synthetic, it's whole plant extract. Now is, however, a synthetic. Sativex has been approved for neuropathic MS pain and leading tractable cancer, being non-responding to opiates, and now is approved for non-related chemotherapy. But we do use these off-label for a number of symptoms. So I want to get a little bit into the research, and hopefully you can take the caveat at the beginning of the presentation, show the limitations that we've had regarding research to date. So just to understand a little bit about how pain is processed with regards to the cannabinoid system, we do know that there are CB1 receptors in our main processing pathways, whether that's in our skin or primary sensory neurons. We do know that there are receptors in our spinal cord and processing areas of the brain. We do know that augmentation in the cannabinoid system can lead to nociceptive threshold changes. And we do know that in our immune system, pro-inflammatory molecules can be decreased. And we do know through various studies that there are synergistic effects with the cannabinoid system, particularly on the endogenous opiate system. So the first study I want to talk about is smoking cannabis chronic neuropathic pain. This was done by Aware out of Quebec. So to be included in the study, to have neuropathic pain in at least 3 months. And now it's caused by trauma or surgery, and patients had findings of validated or on physical exam. They were all cannabis naive subjects, unfortunately only 23 patients. It was a randomized double-blind placebo crossover design, 4 different groups, different concentrations of THC, 2.5, 6, 9.4 versus placebo. And it was delivered as a single smoke inhalation 3 times a day. And there was a 4 to 14-day period where patients would consume it for 5 days and then they would have a washout period and they would do this again. What was found was that the only statistical significance was the 9.4% THC potency when compared to placebo. So the 2.5-6% did not change. Did not have a significant outcome on neuropathic pain was found with a p-value of 0.023 at 9.4% potency. And now pain was measured through a 11-point memory rating scale. Secondary outcomes was anxiety and sleep improvements reported by patients. But it was smoke cannabis, which we don't really recommend, and it was only 23 patients, unfortunately. But it did give us some information that perhaps neuropathic pain can be helped with cannabinoids. The next study I want to talk about is cannabinoid interaction. And this study really looked at to see what is the effects if you use cannabis on opiate metabolism and pain. So this was a design study where all chronic pain patients were 21 again, unfortunately, a small study. It was a huge range of different pain symptoms, from MSK to cancer, fibromyalgia. They were non-naive subjects, and they were all on either sustained release morphine or oxycodone. It was a randomized double-blind placebo, and they had inhaled vaporized cannabis, and that was delivered 3 times a day for 5 days. What was found is that there was a statistical significance of 27% reduction in pain score for patients who were using the cannabis. And there was no significant effect on opiate metabolism. And when they did the study was measure different metabolites of opiates as they consumed with cannabis, and there was no change in concentration. The conclusion from this small study was that perhaps vaporized cannabis can augment the analgesic effect of opiates, and perhaps are safe to use given there is no cross-metabolism. And in extrapolating that a little bit further, perhaps using cannabinoids allows us to lower opiate treatment. Another study for cannabinoids for treatment of chronic non-cancer pain. This was a systematic review of randomized controlled trials. There was 11 RCTs, about 1,200 patients enrolled in these high-quality trials, but they were non-cancer pain. This is based on formal pain scale that patients had cancer in all of these studies. 7 of the 11 trials did indicate positive benefits of cannabinoids. And this was a mix of different cannabinoids in each study. It could have been like static, which is mixed malts, or now synthetic or cannabis. And pride and pain was the primary outcome in all of these studies. Which was interesting in some of these RCTs is that gabapentin and TCA were used as a control group. Cannabinoids are still found to be as effective in some of these studies. Several trials also indicated secondary outcome improvements, particularly in sleep, muscle stiffness, and spasticity. And out of 1,200 patients, there were no serious adverse outcomes or side effects reported. The Canadian Pain Society has a consensus statement regarding cannabinoids in terms of its appropriate use for path pain. And I think it's really important to look at cannabinoids as a class of therapy. And anticipate in the future we're going to see more options in this class as we begin to isolate specific ingredients in the plant and measure their effectiveness. So for now, it is still recommended that cannabinoids are third-line therapy for neuropathic pain after the first or second line above. However, I think a lot of the physicians in the pain community think that for the next 2 years we'll see cannabinoids jump to second-line therapy over opiates, really just based more so on their safety profile compared to opiates. Another study was in Journal of Pain Symptom Management. It was a double-blind randomized placebo-controlled parallel group study, and it was looking at the safety and tolerability of THC extract as well as just the THC extract. And this was in cancer-related pain. So 3 groups were THC extract, which is essentially the Sativex component, a pure THC extract or placebo. And again, these were relieving pain in patients with advanced cancer. There was 177 patients who were reporting inadequate analgesics despite chronic opioid dosing. 2-week multi-center double-blind controlled trial, and then 3 groups again were THC extract, THC extract, placebo. Primary outcome was again reported pain at a numerical rating scale. And what was quite interesting in this study is that there was statistical significance in improvement in pain, but only for the THC extract compared to just pure THC extract compared to placebo. And that reporting was about 30% reduction in pain. Opiate dosing was not changed throughout the study, they kept the same. And again, drug-related adverse events were really mild to moderate severity, no significant or severe outcomes. This is really interesting to open our eyes to perhaps that the combination of THC and CBD together is perhaps more beneficial for specific types of pain compared to just pure THC. I'm going to get into cannabis as nausea and vomiting. We do know that nausea and vomiting is quite complex, but controlled by chemoreceptors are primarily, and some main receptors are involved in dopaminergic pathways as well as serotonergic. What's interesting is CBD cannabinoid has been shown to inhibit 5-HT3, and that cannabinoids may release or control the release of serotonin in presynaptic neurons. And perhaps this is the way that cannabinoids are affecting the reporting of patients who seek improvement in nausea and vomiting. And then, of course, cannabinoids may be able to control some of the triggers that patients have as well that promote nausea and vomiting as listed below. The best study I could find for nausea and vomiting was a BMJ review in 2001. It was a quantitative systematic review. It was 30 randomized comparisons of cannabis with placebo compared to antibiotics. 1,400 patients roughly, just under. And this review was only synthetic cannabinoids. It was non-herbal cannabis. And so they had naloxone or dronabinol, which is the American version, is similar to naloxone. And then they had IM cannabinoid, which I've never seen before. But they did find the results that cannabinoids were more effective than some of the listed drugs there that we use for nausea and vomiting with a related of 8. There are some drugs that we use more commonly today that aren't there. It's a little bit outdated. And we do know that it was overall effective for patients, and that a lot of patients reported in further chemotherapy cycles that they would prefer using cannabinoids. What was interesting is that patients who were on very low or very high immunogenic chemotherapy, for some reason they didn't get the same effect as people that were somehow in the middle, and I don't really understand why. A lot of the side effects and are reported there were being hallucinations probably, but no, again, serious adverse outcomes other than that. I tried to find some research with inhaled cannabis for non-drum, given that you get much more potent rise in your serum cannabinoid level when you inhale it. And I really couldn't find much, unfortunately. This is just technical reports from 6 states, and there's about 750 patients in various different states looked at self-reporting of improvement in non-vomiting, and then just scored it 0 to 100. And patients were reporting improvement. It wasn't a very good study by any means. Unfortunately, I didn't find anything else for inhaled. We still haven't studied CBD to the full extent and how that may affect nausea. There's a number of animal models out there that show that there is suppression of vomiting by the serotonergic pathways. And there is a phase 2 trial of THC extract in patients with chemotherapy-induced nausea and vomiting. And so far, the phase 2 trial has shown positive effects. But at the end of the day, we still need ongoing research for all the different ingredients, whether it's individually or together, to better understand which doses or which combination of ingredients help patients. With regards to appetite enhancement, which is often a problem for a number of patients on chemotherapy, there's a study here on THC and how it may aid chemosensitive reception in cancer patients. This is a result of a randomized double-blind placebo-controlled trial. So patients were included if they reported poor appetite or poor chemosensory alteration, so food just didn't taste good. It was a randomized double-blind study to two different groups of THC, 2.5 milligrams. There's 24 patients versus placebo. They were given twice daily for 18 days, and they had a couple of measures: taste and smell survey, 3-day food record, appetite and macronutrient preference assessment, quality of life questionnaire, and then they had an interview. And what was found is that patients in the THC group reported improvement in chemosensory reception. They also had a different change in protein consumption. They also reported having increased quality of sleep and relaxation. Both groups, interestingly, had total caloric intake increase. So THC may enhance appetite. And the method by which this works is probably through policy. We don't fully understand, but this is probably the best theories out there. So cannabis and cancer. So this is probably a conversation that I have at least once a week, and there's other things that patients are coming into talking about. So I know a patient is saying, I'd like to use cannabis to cure my cancer, chemotherapy is poison, I want to use natural options. I've watched online videos of marijuana oil, melanoma, and away, and I want to use it for instance while curing my cancer. So this is what patients are finding online on the internet, watching YouTube videos, and coming in and asking, what really happens with cannabinoids and cancer. And of course, they don't try to understand what the evidence is or what anecdotal evidence is. When I have conversations with patients, I do address some of the unknowns. Primarily, I've encouraged them to try traditional therapies, and if there are going to use cannabinoids, it's really for support for symptoms at this point. But there is a lot of interesting stuff that's being uncovered for cannabinoids and cancer. It's just in the very, very beginning stages. So this is a number of in vivo animal studies. This was published just last year. And it showed that there is in vivo a number of different cancers that they've looked at, that there is perhaps decrease in tumor invasion when you use cannabinoids. There's not a lot of studies yet evaluating patients and with their specific cancers. But we do know that overall, we think that overall cannabinoids are quite safe. There is a phase 1 trial on the effects of THC in patients with recurrent glioblastoma multiforme. And they did show that was intracranial injected THC, which is really interesting. When used with chemotherapy, it showed a reduced tumor cell growth. But again, these are really the beginning stages of, hopefully years of research to really understand what ingredients, what doses, how they work with our current agents, what we expect from them. But I think patients see, a various websites, pick one of these articles, it's very, very quick to go from, an in vivo study that showed tumor growth versus recession to, cancer, unfortunately, that's some patients think. What's interesting, this came out about 3 or 4 days ago. So Sativex, produced by DW Pharmaceuticals, just did a phase 2 exploratory placebo-controlled clinical study. And so using the THC-CBD extract, they had 21 patients with recurrent GBM. They randomized these patients to THC-CBD extract plus temozolomide versus placebo temozolomide. And what's interesting is in the extract group, there's an 83% 1-year survival compared to 53% for the placebo group. And so that translates to 550 days for patients using the extract plus the chemotherapy versus placebo plus chemotherapy. There wasn't severe adverse events, but there was no side effects reported. Again, this is just a phase 2 trial, just came out the other day, but it's really starting to give us insight into perhaps cannabinoids have a role in the field of oncology, but there's still a lot to be discovered. Okay. Risks of cannabis. So there's a couple of definitions that I want to get through first. LD50 is the dose at which 50% of animals will die from the drug. ED50 is the effective dose for half the population. TT50 is the toxic dose. And therapeutic index is the LD50 over ED50, which is our safety window. What's quite interesting is cannabis has a huge safety window. The LD50 is 1 to 20,000, 1 to 40,000. Which essentially means, and it's almost impossible, for a toxic dose in a controlled environment, you'd have to smoke 15 pounds of marijuana, which can't happen. So when you look at, that's a really big joke. If you look at therapeutic index of various drugs, cannabis is well over 1,000 to 1. So, in terms of reducing a toxic dose, what's nice about prescribing for me is that there's a huge window of safety in terms of toxicity. There are perhaps negative outcomes if you do prescribe, but it's not directly from cannabis itself. You can compare that to other drugs there, where we list various therapeutic indexes that we use. When you look at the dependence rate, overall, cannabis is around caffeine, 9%. And it's quite interesting. I think we at least I see some patients that are overdiagnosed with cannabis dependency. If you really ask them why they're using it, they'll tell me that it allows them to get sleep, which allows them to get to work. And so a lot of patients are using cannabis already from straight self-medicating, but it's allowing them to function at a higher level. I do see probably somewhere between 5 and 10% of patients that are misusing it or overusing it. And it's impairing their ability to do their activities. But overall, when you compare that to, I believe, synthetic opiates are around 25 to 35% in terms of dependence rates. Cannabis is a lot lower. If you plot dependence potential and compare that to the safety ratio, you'll see that opiates are in the top left of the corner, and cannabis is on the far right. So it has a lower dependence overall, and it has a higher safety ratio. This study was done not too long ago, looking at physical health problems of recreational cannabis users in New Zealand. They launched a longitudinal study. They followed patients for 38 years. They controlled tobacco use, their childhood health, and their socioeconomic status. And they looked at cannabis user dependence at the various ages listed there. And they measured various physical health outcomes: periodontal health, lung function, systemic inflammation, metabolic health. And the only thing that they found in cannabis users was that they had worse periodontal health. And I don't know why. It's quite interesting. But there was no difference in physical health compared to for lung function, or systemic inflammation, and metabolic health. Whereas if you look at tobacco, there's all negative outcomes on those measures. So the conclusion was that perhaps there's no harms with physical problems if you use cannabis. This isn't a recreational group as well. This isn't in medicinal users. Cannabis side effects. So I've divided this into common, less common, and rare. The most common side effects I see are drowsiness, dizziness, dry mouth, tachycardia, and that's all caused by THC. I also see patients who report euphoria, feeling high, which some patients report as a side effect, some patients report as a side benefit. And that is higher with inhaled compared to oral consumption. And then you do get vasodilation, so you get some conjunctival injection. Less common is nausea and vomiting, and that's really patients who are overdoing it or taking too high of consumption. Paranoid anxiety is really with specific types of cannabis, high THC or specific strains which we call sativa, and I'll explain that later. They can promote energy, so you give anxious people caffeine and they feel more anxious. You give anxious people sativa cannabis, they feel more anxious. And it puts them in the spectrum of anxiety or paranoia. Mild amnesia, that's transient and it goes away. Rare side effects are hallucinations, psychosis, paranoid delusions. And again, this is really high THC users, typically inhaled. And the risk, there's no known cause. Cannabis does not cause schizophrenia. It can cause a transient psychosis, but the risk is really in patients with a predisposition for it. So patients have a strong family history of psychosis or schizophrenia. They should avoid using THC. Cannabinoid hyperemesis syndrome is quite interesting. Out of the 2,000 patients I've seen only one. I don't know if that's just the patients are telling me or just going to the emergency room with symptoms. But that's a syndrome where it's a cyclical vomiting syndrome. They wake up every morning and they feel nauseous and have to vomit, and then they take a hot shower, and that somehow relieves their symptoms. And the only way to fix this is abstaining from cannabis completely. So it's fairly rare. We don't understand what hot shower is. Some theories are that has to do with histamine. We don't really understand why some people get hyperemesis syndrome and others don't. There is some studies that show that if you use heavy amounts of cannabis at a young age on a developing brain at the age of 25, that you may have a life worsening depression and anxiety. And some of the studies in functional MRI scans, and this is really small numbers of maybe 10 to 15 patients, show frontal cortex shrinkage. We don't understand what that means long term, but for now, the recommendation is on a developing mind. You should be very cautious with using cannabinoids, particularly THC, until we better understand exactly what the risks and benefits are for that population. When I do a medical assessment in my clinic, I look at a number of factors. I think about, is this the appropriate treatment for my patient? What will the risks be for that specific patient? And given that the evidence is really just emerging, I'd like to see if they've really tried evidence-based therapies prior to prescribing cannabis. And then I also look at if they meet any indications contraindications, such as maybe under the age of 25, if they've had serious mental health disorder, if they have ongoing substance use, I don't think it's ideal to patients use cannabis. We don't know if serious liver or heart disease will impair absorption. So you have to be cautious or choose the delivery methods specific to patients with medical issues. Pregnancy and breastfeeding is contraindicated. And I've never seen an allergy to cannabis, that's theoretical. When it comes to consuming, patients are using so many different ways of consuming cannabis. And it's really just anecdotal reporting of what they perceive the benefit is. Some patients do what's called raw juicing. They take cannabis leaves and put it in their ninja blender with some kale and smoothie mix, and they juice cannabis and they swear by it. It's not even active at all. They're just eating cannabinoid acids. But you have to heat the plant before the cannabinoids are actually active and work on the CB receptors. But nonetheless, patients still doing that. Ingestion is probably one of the more common methods, and that's also known as edibles. So some patients may make their own edibles, but when I'm prescribing, I have the luxury of prescribing oil in very specific concentrations that I like to titrate the exact dose. Some patients smoke, which we don't recommend. Vaporizing is the recommended route for inhalation. And what's nice about that is we can bypass we can bypass metabolism in the stomach and liver if we inhale it directly into the bloodstream. First pass metabolism. There is some sublingual tinctures that some patients make. And some patients are actually taking cannabis, particularly CBD strains. They put it in a crock pot with some coconut oil, and then they make a rub. And some of them swear by it for osteoarthritis, but again, no real evidence or research for this. But probably no harm to using a topical CBD cream for osteoarthritis. But in terms of what's available for physicians to prescribe a controlled environment, really just we can only deliver through two controlled methods. That's the lungs and the gut. So that's either inhaled cannabis or oil. And it has to be in oil because of that solubility. When you inhale cannabis, you get rapid diffusion into the alveolar capillaries and enters the bloodstream. It can take 5-10 minutes to onset, and the effects last about 2 to 3 hours. You do get a small amount of metabolism in the lung, liver, brain, and this is a good way to rapidly deliver a high dose of cannabinoids. And there are different ways that you can affect bioavailability. The availability is listed there. The two ways of inhaling are smoking and vaporizing. We never recommend you smoke cannabis. When you smoke cannabis, you burn and waste a lot of the cannabinoids. You're overheating them. And you get toxic byproducts. And it's quite inefficient. So patients waste 30-40% of their cannabis just by smoking it. And one of the ingredients over 400 degrees is benzene, which is like a carcinogen. On the other hand, vaporizing goes to usually a maximum temperature of about 400. And how these devices work is it just heats the cannabis plant through convection or conduction. And it just gets the temperature just enough to vaporize the main ingredients off. And then that can be absorbed. And that's a much more efficient process. It produces less odor. There's no toxic byproducts. Different cannabinoids, and again, there's about 80 to 100 cannabinoids, THC, CBD being the most medicinal. Different temperatures will release different cannabinoids. So for most patients, we recommend somewhere around 350 to 380 to take the majority of the cannabinoids. But before you heat it again, it's not active, it's inactive. When it comes to ingestion, then we go through the route of metabolism. And THC ends up being converted to 11-hydroxy-THC, and this is actually even more potent in terms of psychoactive effects potentially. It can be stronger than CB1 and CB2 receptors. And that's through various CYP enzymes listed there. Again, before patients consume this oil, companies that are making it are heating them and then diluting them. So it has to be activated by heat again, which is a decarboxylation reaction. Patients who ingest too much can get a lot of sedation, or they get a high amount of euphoria if they overdo it, which a lot of patients do. And that's why it's important to have physicians help you titrate that. There's a lot of intra-ingestion variability, whether you consume it with food, whether you're on medications, how often you're using it, if you have liver problems. And the onset of this is much longer. It takes about 30 minutes to 2 hours to onset, but it can last about 5 to 8 hours. So it's a good way to use long-acting cannabinoid therapy. There's a lot of different variables to consider. This is just a quick graph showing the rise in plasma THC concentration compared to inhaled versus oral. So patients are using too much inhaled cannabis. I tend to try to convert to oral. So just like we do in most fields, trying to switch long-acting if it makes sense. Scripting and dosing. When you look at different strains of cannabis, there's two numbers printed. It's a THC number and a CBD number on all strains. The first number is THC, second number is CBD, and there's some examples there. And all the cannabis strains look completely different. There's two major types of strains, or families, which are based on genetics. One is called the sativa, and the other is called indica, or what I call indica kush. And so indicas tend to be more sedating, and they have a certain terpene flavonoid profile that probably augment THC and CBD to produce more sedative side effects. On the other hand, sativas have a different mix of terpenes and flavonoids that tend to promote more energy. And again, we don't fully understand what it is in each of these strains and as to why they're producing such different effects. different patients will use different strains at different times of the days, and they make different potency levels. So it's quite complex, especially for a naive patient. If you look at these are a number of companies that are licensed by the government to produce cannabis. There's three major groups of strains. We look at THC and CBD. There's a huge cluster of high THC with no CBD strains. And then there's a mix of almost 1-to-1 ratio of THC CBD strains. And then there's high CBD low THC strains. And that tends to be, if you look at the genetics of the plant, that tends to be the three major groups that you can produce with one specific strain. This is what some of them look like. So you can see those are some bottles on the left, just a really small bottle, and one right where you have 100 cannabis or herbal cannabis dried. When it comes to dosing, what I'm doing in my clinic is it's quite individualized, and it really relies on great extent and titration. Start low, go slow. We use high CBD primarily first, and then slowly titrate up THC to effect. If patients have prior experience, we use that kind of guide our initial starting point. We look at different patient factors. So, is there a better way we live for this patient? Should we avoid ingestion? Should we avoid inhaling? And we look at also synthetic cannabis, which is now better for this patient. And at the end of the day, we're trying to get the lowest effective dose of THC for their condition. When it comes to documentation, we go through a number of different things with our patients. Our treatment agreement, driving safety, smoking harms, we address the long-term effects. We don't know what long-term use of cannabis really does. The concern is really on the developing brain. But we don't really know if you use cannabis for 50 years, what it does to your mental health. We don't have that data. So we warn patients that's a no-no. We don't encourage anybody to smoke. We tell everybody to not drive. They're using cannabinoids at least for 4 hours when they're inhaling. Prescribing cannabis is far too complex. It's much easier for me to write a fentanyl prescription, sadly, than a cannabis prescription. I have to go write a medical documents, and then I have to sign a specific treatment agreement with each patient, which should be for every controlled substance. And then I have to sign a special document for the company that the patient signs up for. So it's great to do administrative burden for physicians. But that's the system that we have to date. And then patients don't really register for one company, then that's another problem, because as like pharmaceuticals, we can just run an assembly line, print some more. When you're growing a plant, it takes X amount of time to produce it, and you could run out of that, and then patients get frustrated when that strain doesn't get effective, and then it's pulled off the market until another 3 or 6 months. It's quite frustrating system, I must say. The clinic that if you are for patients with cannabinoid therapy, I think clinic really doesn't matter. There's a huge range of people doing a huge range of different practices. I know our clinic trying to develop guidelines based on our experience. We have about 35 physicians. We prescribe cannabinoids like a class of therapy. We don't look at just plant. We look at synthetics such as additives and alcohol. We see patients in person. We don't charge patients. CSS will get covered. We do have pain designations from the physicians. We have psychiatrists that work with us. We have emergency physicians. We have rheumatologists. And we do provide patients with extensive education counseling after they get a prescription. It's very typical to most medications. There's a lot of confusion. They don't know how to order these things. They don't know which ones to order. So we provide educators to help them understand all the different ingredients. At all of our visits, we're looking at other medications, particularly opiates and benzos. We're looking at if we're going to get effective with cannabinoids, we should be anticipating a reduction in opiates and benzos, and hopefully that's reducing some harm or the risk of respiratory depression. We see patients every 6 months, and we use validating questionnaires to assess how patients are doing on pain, anxiety, or depression at every visit. There's a lot of different patients we see in our clinic. MS is a condition, particularly anti-neuropathic pain. Cancer patients, we do see a lot of patients with various side effects, nausea, vomiting, fatigue, poor appetite, insomnia. A lot of patients are able to use this in conjunction with their therapies. Chronic pain syndromes we reserve the Verbora resistant cases. And our goal in those patients are really to harm reduce. A number of neurological disorders we do treat, we try to alleviate symptoms, and we do see a number of patients with inflammatory arthropathy. We don't recommend patients with mental health disorders using cannabinoids yet. It's really for treatment-resistant cases or patients who are self-medicating or doing harm reduction or switching them from perhaps high THC to high CBD. CBD is being studied for anxiety and antipsychotic effects, but still too early to really recommend that as a therapy for such a therapy. It's very line therapy. So quickly to summarize, THC and CBD are the best studied phytocannabinoids. They operate in CB1 and CB2 receptors. And THC is psychoactive, whereas CBD is not psychoactive. Cannabis has never resulted in direct death when consuming it. It's not toxic. And the side effects tend to be well tolerated. There's moderate quality evidence for neuropathic pain, nausea, vomiting, perhaps appetite enhancement. And there's a lot of secondary outcomes showing improvements in the literature. We're really at the beginning stages of understanding the effects of cannabinoids on cancer. It's hard to really recommend as therapy for cancer specifically. Dosing strategies start low, slow titrate up THC to affect monitor patients with validated questionnaires. Various methods of consumption, such as vaporized, ingested. Now that we have this licensed system, which has been in existence for about 2 years, what we're going to see is as these companies begin to turn profit, I anticipate a lot of them start funding research. At the clinic that I'm at, fortunately, have been granted some funds to perform 7,500 observation studies, 7,500 patient observation study on the reduction of synthetic acids and cannabinoid use. And so hopefully we can push that data in a year or two. But I anticipate as there's more and more incentives for these companies that funding will match and get evidence to support what we see anecdotally in front lines. What you'll also see in the next few years is that a lot of the technology we've seen in pharmaceuticals will start to make their way to the cannabis realm. So patches, IV delivery, IV injections. I think there's a company working on curating pods for teas. So you're going to slowly start to see a lot of different technologies, at least in the medicinal market. And I know there's a whole other recreational market, but who knows what that will be like. But as we get more standardized, as we get more research, we'll feel much more confident in prescribing because we'll be able to deliver exact dose. Before I conclude, I just want to show a quick video. If that's okay to have time. It's about 3 minutes. And then I'll take questions if that's okay. I think it's important to see what a patient really goes through and what it is that they experience when they use cannabinoids.
Hi, my name is Rick McAdam from Toronto, Canada, and I'm a medical cannabis user. In 2015, I was diagnosed with a deadly stomach cancer, and in September of that year, I underwent an esophagectomy, which is a massive 8-hour surgery to correct this. They removed a third of my stomach and all of my esophagus. I was in hospital for 10 days, and then I've been recuperating for the last year. In the hospital, as well as after my discharge, I've been prescribed a lot of pharmaceutical painkillers and was using these to address my pain management. However, I found in a very short period of time that the side effects were worse than the benefit. I was referred to the medical cannabinoid clinic and was trying medical cannabis to address the issues of lack of appetite, not being able to sleep, and pain management and anxiety. I've had great success in all of these areas with very little in the way of any side effects whatsoever. My quality of life has been dramatically improved by the use of medical cannabis. Big issue for me is my weight loss. I've lost 170 pounds in 1 year, and we're still trying to make sure it doesn't go any further. Medical cannabis has been the only thing that's been able to stimulate my appetite. Since having this surgery, I have no appetite whatsoever, and this has been a great aid in helping me to get food down. It's improved my anxiety because under the threat of cancer, I'm in remission at the moment. It's been a life-changing experience. It's affected me and my family. And so the benefits of medical cannabis have played out to the people around me as well as improving my own life. There is a need for education around its medical uses. I think it's a valid one, and that has proven to be so. to the people that had concerns around me. Since then, my family and friends don't have any concerns about it. The problem that I had using regular pharmaceuticals in particular was I had trouble going to the washroom. For me, that's a significant issue because I also have trouble eating. And it's very important that if I try and get my food intake going, that I'm also able to eliminate it as well. I don't have any of those side effects with medical cannabis.
So I just think it's important to see what quality of life we can do for patients that are the right candidates for cannabinoid therapy, and that patient has quite a tremendous response. So that concludes my presentation. Take any questions?
Maybe we can start with questions here, and if there's remote sites, Fifi.
That's great, thank you. Can you tell me how many of these, two questions, how many of these private clinics are there across the city now, and how are you guys funded?
So at our clinic, the one I work at is in Toronto. I think we have one in Toronto, one in Barrie. There are other clinics, but it's a different company.
So how many are there across the GTA? Do you
For our company, there's
in
just
general. In general.
I don't know. Like I know there's other clinics. There's probably about 10, I would say, 10 different clinics.
Right.
I just know at our clinic we have 2 clinics, one in Toronto, one in Barrie. Our funding is OHIP. We pay a percentage of our income to the company that runs it, and they do the operations. And then we do have some research that we do with some specific companies as well, and that's 100% of our funding. Yeah. And it's actually quite hard, especially when you're providing an educator that's coming out of an OHIP, it's coming out of the physician's income, to provide an educator in addition to other staff to help patients to do the right thing. So it's quite a challenge, I would say. Across the country, our clinic has about 13 clinics. And I'm the medical director now of this company, and my goal is to kind of synthesize all of our information to get protocols so that we're not operating in silos and that we're all kind of doing the same thing and practicing the same kind of medicine.
Investors then in the company? So is this like a publicly traded company?
Yes, it is now a publicly traded company. I don't know how long ago they went on the stock market, but there are private investors as well in it. Yeah.
Thank you.
Any other questions? Great.
Yeah.
With cancer patients, how do you liaise with the oncologist and the palliative care doctors in terms of symptom management?
Yeah. Well, what we do is whoever's referring to us, we provide a consult note and then ongoing notes back to the referring physician. I don't know if there's a better way of communicating or integrating it. It really depends on who's referring to us. So if it's an oncologist that's referring to us, we're just sending the notes back and listing what we're doing and what our goals of therapy are. And we're really just getting updates on what the patient's telling us because we're not getting necessarily the notes the other direction.
Do patients have to be referred, or do they self-refer?
So at our clinic, we want all of our patients referred because we think it's very important that the referring physician, who's probably doing most of the primary care or most of the care at that point in time, is aware of what's going on. So we don't accept like walk-ins. And that is different at other clinics. I do think that some clinics just take anybody.
Great. Thank you very much.
Okay.